Yes, good evening everyone. Welcome back to my YouTube channel. Today we are dealing with the normal electrocardiogram or ECG. Normal electrocardiogram or ECG. The first thing we are going to do is to look at the nomenclature of the waveform of the ECG waves, segments and the intervals. The ECG has waveforms, segments and the intervals. So we are going to see the normal, how they look like, and then how we name them, starting and ending of intervals and segments, and the waveforms. Let's start. So the first, remember this is basic, this is very basic. If you have already some background, you already know this one. If you are a starter or a new one, then let's go together. This is P wave. This is a waveform, any deflection from the baseline. Where is the baseline? The baselines, they are these ones, these straight lines. So any deflection, either positive or negative, it is a waveform. Then P, what does P represent? P represents atrial. We already said these ones, atrial depolarization. P is for atrial depolarization. Then it has two parts. You can divide it into two parts like this. First part is for the right atria, second part is for left atria. So that's how we take it. To remember, we have two atria, so each atria has one part. The first one is for right atria because it is where they say node is located, so the depolarization starts from right atria and then spreads to left atria. So the left atrial depolarization come next. Then we can give it in the normal ranges, but we shall do it later. Then the next one is Q wave, small q, I've given it Q wave. What does it represent? It represents septal depolarization. Whenever this Q is, so it is for septal depolarization. We are going to give it its normals because sometimes it is there and it doesn't represent septal depolarization. The next one is R. In the R wave, it is for R. It is still ventricular depolarization. Ventricular depolarization. The major ventricles. Now the S, yeah, S, sometimes if it's there, it represents depolarization of the basal, parts of ventricles or free wall, ventricular free walls. We can name it like that. This is the S wave. I did not named it. And then the next one is the T wave. T wave is bigger than P always. So T wave. Then the T wave is going to be ventricular repolarization. Ventricular repolarization. These are waveforms. You have not seen one waveform, which is atrial repolarization. We have, when you depolarize, you must repolarize. So all cells, when they depolarize, they must repolarize. Also the atria repolarize, but the repolarization is not fast, it is small, the waveform is small, and two, it is hidden within the QRS complex. So that's why we cannot see it. Whatever we can't see on the ECG, it is insignificant clinically. So we leave it out always. And then sometime we can see another deflection, but not always seen. we can get another waveform here, and forgotten to put it, and it's called the U wave, which is repolarization of basal parts, but not normally given, or not always present. And then this one, the cycle continues. This is P again. We have finished one cycle, one cardiac cycle is finished, same the second one. So now next is what are the segments. First, how do we define the segment? Segments are just baselines, or in bracket isoelectric lines where there is no deflection. Where there is no deflection, so they are isoelectric line, and they are between two waveforms. For example, isoelectric line between two waveforms. Between P and Q, we have an isoelectric line, so that is a segment. Between S and T, we have an isoelectric line, that is a segment. And then also between U and P, or between T and P, an isoelectric line, it is a segment. Another one big important thing I'd forgotten, the junction. This is a J point. J point, a junction between the ST segment and then the S wave, the end of S wave. It is a J point. There are conditions where that J point is elevated. We shall see them later. So segments, which segments do we have? We have a segment. We have a segment from here, end of P, and then to the start of Q. This segment is the PR segment. PR segment. We have another segment from the J point to the start of T wave. We call it ST segment. And then we have another segment. U is not always present, so I am not considering it. From the end of T wave to the beginning of the next P is TP segment. So first, here is starting. Here is PR segment. Yes, segment, that is starts from end of P wave to the start of Q wave. If not Q wave, it's R wave. So Q wave is the first negative wave after P. If it happened that the first wave is negative, it is Q wave. If the first wave after P is positive, it is R wave. So S is always negative after R wave. This is a QRS complex. QRS complex, three waveforms can be there. So what does it represent? It represents conduction through the FV node. FV node conduction is, FV node is so small it does not produce any waveform. It is depolarized but no waveform because it's a very, very small tissue. So we don't say nothing. That is it. PR segment is so important that if it's prolonged, like its duration, we say blocks are there, heart blocks. Another one is ST segment. ST segment, it starts from the J point to the start of T wave. What does it represent? Remember the cardiac cycle, not the cardiac cycle, the depolarization waveform, like graphically. Remember we did this. This is depolarization. You do something like this, and then we say this is phase 2. So it's ST segment. It represents phase 2. At full depolarization of the ventricles. Before repolarization. That is phase 2. Of the what? Cardiac action potential. Phase 2 of the cardiac action potential, that is ST segment. And then another one is the TP segment. TP segment is what? End of T wave to start of P wave. End of T wave to the start of T wave. What does it indicate? It represents phase 4. Phase 4, yeah, of the cardiac action potential. That is what it represents. Before we depolarize the next time, or we generate another impulse from SA node, we are on phase 4. So phase 4, it is TP segment. Now the next one, they are intervals. Intervals. What are intervals? They consist of waves and the segments. So in ECG, we have these intervals. On ECG, we have the following intervals. We have PR interval from the start of P to the start of QRS. So this PR interval is there. And then we have QT interval from the start of QRS to end of T wave. This is QT interval. Start of QRS to the end of T wave. So we start PR interval. What are the demarcations? Starts from P wave, beginning of P wave, to beginning of QRS. So it has, what are the components? It has components, again we write, because some people are using these ones for exams. Components, it has P wave, it has PR segment. Those are the two components, P wave and PR segments. And then next interval, again it is for conduction. It represents, again, let's write that one. It represents conduction through the atria and the AV node. The next interval, it is the QT interval. QT interval. How long is QT interval? What is the, where does it start from, or demarcations? Starts from beginning of QRS to the end of T wave. So what are the components? The components are QRS, ST segment, and the T wave. So we have finished intervals and segments. So whatever we have named the normal EKG and all its components. The next part is going to be giving the normal values or durations of each waveform and interval. Stay tuned. The next thing we are talking about is the normal parameters of the waveforms, segments, and intervals. What are the norms? So again, starting from P wave, what are the normal parameters of the P wave? Morphologically, it has to be like that, not peaked, not, but a clear contour has to be there of the P wave. And if you were to go from the start to the end, this one, it has to be less than 2.5 millimeters. Less than 2.5 millimeters. Less or equal to 2.5 millimeters. And then if you go amplitude, it will be also same, 2.5 millimeters. If we talk on the ECG paper, these are calibrated. Horizontally we are having time, and then vertically we are having voltage. So when we look at the ECG itself, we shall convert this into voltage and then time. Otherwise we can convert them even here, 0.1, 0.2 to be 0.25 millivolts, and then here it will be 40, 80, 100 milliseconds. SO equal to that. It shouldn't be tall, it shouldn't too tall, it shouldn't be too wide. That one is done. P wave. That's how it should be. The next is the PR segment. The PR segment, it's just a straight line or a baseline. So it should be, it ranges from 80 milliseconds to 120 milliseconds. If you get an ECG paper, then you try to measure PR segment, it should be between these ones, 80 milliseconds to 120 milliseconds. And then next is the PRI interval. PRI interval, it should be 120 milliseconds to 200 milliseconds. 120 milliseconds to 200 milliseconds. That's what it should be. If it is prolonged, then we shall see those conditions. Yeah, conditions for prolonged PRI interval, conditions for wider P waves or peaked P waves. Wider P waves if it's more than 100, or peaked P waves more than 0.25 milliseconds. You shall see that one. The next one is the QRS complex. A complex combination of many waveforms. So it has duration. We talk of duration now. It has many normal parameters. Duration, it should be, we have the normal one less than 120 milliseconds, the normal one, but it from above 120 it is wide, but 110 to 120 it is slightly wide. Now below 110 milliseconds, that is a normal, nah? Purely normal. It should be, ventricular conduction should happen so fast, conduction through the Purkinje system so fast. So complex is less than 110, they are purely normal. You most cases will find when PQRS complex duration is 90, 186 milliseconds. Then Q waves. We said Q waves if they are there. Okay, amplitude. Wait, that was duration. QRS complex net height, it should whether positive and negative. If S wave is present and the R wave is present, then the net, not the net, the total. If R wave is two big boxes and S wave is one big box, the net, the total is going to be 3 big boxes. So amplitude, it depends. In limb leads, it should be at least more or equal to more or equal to 5 millimeters in limb leads, that is 0.5 millivolts. In chest leads, it should be more or equal to 10 millimeters or 1 millivolt. That is QRS, amplitude. That is amplitude, that is voltage. And then Q waves, if they are present. Q waves, if they are present, normal Q wave parameters, it should be, like for example, this is the Q wave. This is a Q wave, this is R, this is Q. This Q wave, it should be not be more than 40 milliseconds. It should not be more than 40 milliseconds. So it should be less than 40 milliseconds. That is wide, and not more than 0.1 millivolt, and not more than 0.1 millivolt. 0.1 millivolt is 1 mm high. So those are the normal parameters of a normal Q wave. Otherwise, it slightly taller and slightly taller Q waves can be there in lead 3, but it should not appear in other inferior leads. You understand? Another one is QT interval. QT interval. QT interval, we said we defined it already. So the normal one, it depends on the population or gender, female or male, and also depends on the heart rate. Gender and the heart rate. So for this case, when you get an ECG, I have one here, like this ECG here, we try to find the QT interval. You shouldn't just take it like that. Otherwise, it was corrected for heart rate. And the normal in the males, normal range is males should be around 350 to 450 milliseconds QT interval. Now in females are going to be 360 or 370, depending on where you're getting it from, to 460 or 470 milliseconds, depending on where you're getting it from. Sometimes they give 470, others 460. So these are the normals. So what is it can be prolonged or shortened. That's why there is a range. Short QT interval less than 350 or 360. It is a problem. Even longer than 450 or 470, it is a problem. We don't want that one. So this is by gender, but also these ones, gender has been factored in, male or females. Now heart rate. For heart rate, we are going to correct it. We call it corrected QT by Bazet. The guy called Bazet corrected this QT to factor in the heart rate. Longer or faster heart rate, they have shortened QT interval, and then low heart rate, high QT interval. So we corrected it. When you look at the ECG paper, we call it QTCB. QT interval corrected by Bazet's formula. The machine, depending on the setting, can correct it, can calculate it, but we can calculate it manually from this equation. We have observed QT. What is observed QT? The one you can calculate from here. Like this is from here to here, it's going to be QT, and how much is there? That is the observed. Over, we divide everything by the square root of R interval. Divide by the square root of R interval. So you count how much is here. After finding the observed QT, find what is the RR interval, and then you divide, you put in this formula. That is how we can calculate it manually from that formula, QTCB. If you check this machine, this ECG, it is there. Another person also corrected it, but we normally prefer this one, QTCB. Another parameter or another is going to be T wave. So T wave, it is also be round contour. It should be like that, round, and its duration is going to be, it can be from, it is wide, has a wide range from 80 to almost 200 milliseconds. It has a wide range, very wide range. It can be small as 2 millimeters, and then as wide as 5 millimeters. Another one which is not so important is going to be ST segment. Not so important, but it should at least should not be more than 200 millimeters. If we check here, this segment is very short. It should also be at the same range, almost same range, around 80 to 200. You can give, not so important, only under certain circumstances that we can consider it. Okay, this is 200 or 250. This is 5. 250. This one is 5, not 0. 80 to 250. That is T wave. So these are normal parameters of ECG waveforms and everything. Before we look at another parameter, that is the axis, we have to look at the normal morphologies of waveforms in different leads. This is also so important because even with these normal parameters we have already given, durations and voltage, it is useless if we don't know how the normal waveform, like in read V3, will look like. So it is so important to know it, and that is why we are doing it. If you remember very well, this is the hexaxle reference system of limb leads, and this is how we labeled them. We said here at degree 0 degrees we have lead 1, and then here at 60 degrees we have lead 2, and this is the positive what? Positive. Here at 90 degrees we have AVF, and this is the where the arrow is, that is the positive electrode. You remember the placement, huh? This is lead 3 at 90 plus 30, 120 degrees positive, and then this is AVL at negative 30 degrees, and this is AVR at negative 150 degrees, and negative 150 degrees. And then this one, these are chest leads. They have degrees, but we are not giving for simplicity. This is V1, and this is the positive electrode. This is V2 again. This is this exploring electrode, and then this one is V3 exploring electrode, V4, V5, and then V6. Remember we grouped them: anterior chest leads, lateral chest leads, and then right-sided septal leads. We gave all that one, and then we already looked at sequence of depolarization. If we try to draw a simple heart here, we have our simple heart like that. We said these are atria, so the atria is like that. The SA node is here, and then we have AV node here, bundle of fish, and then everything passes, and then the bundle branches, and then depolarizing. And we said the atria are depolarized first. So I'm going to draw, whichever I have the lead, I'm going to draw the normal ECG waveform, how it should appear. So first, how do we place these ones? All there, like the bipolar leads. Bipolar leads, remember, we say these true bipolar leads. We have 1, 2, and 3. These are bipolar leads, and all their positive electrode is on the left side, left leg. So how is the heart depolarized? The heart is depolarized from the atria to ventricles. So the atria is P wave, ventricles QRS, and then repolarization. So if it is depolarized from the atria going to the ventricle, how do we form a positive deflection and how we form a negative deflection? You have to remember, if you didn't watch the first lectures, you have to go back and rewatch or watch, because we already finished these ones. A wave of depolarization moving towards a positive electrode, the deflection is positive. So if this heart is here central, the depolarization will be going this side, towards the left and inferiorly. because the heart is 3D, you have to remember the heart is a 3D structure. It has the inferior wall, anterior wall, the lateral wall, and right. It has all those walls anatomically. So the wave of depolarization is directed because the apex is towards the left anatomically. This is how the positioning of the heart is. The apex is directed towards the left. So the wave of depolarization is from the atria going to the left. The positive electrodes of bipolar leads is towards the left. Bipolar leads 1, 2, and 3. And then also the augmented leads AVL and AVF. Their positive electrode is also to the left. So wave of depolarization will be moving from their negative terminal, from their negative electrode to the positive electrode. A wave of depolarization moving towards the positive electrode will produce a positive deflection. So in these leads 1, 2, 3, 4, 5, the deflections all are going to be positive. AVA is going to produce a positive deflection of P wave because it is from atria are here going this side. P will be positive. And then the septum, will they have Q wave? Let me finish here. And now what is happening in AVR? It is going away. How do we produce a negative deflection? When a wave of depolarization moves away from a positive electrode. So for AVR, positive electrode is this side and deflection is going, depolarization is going this side, in this direction. So it is moving away. So it will be a negative P in AVR. Then complex. Now for the complex, you know the left bundle branch, we said it is, for example, it is heavy node, bundle of his, and then right bundle branch, and then left bundle branch. We say the left bundle branch has two divisions, anterior and posterior division. The posterior division moves inferiorly and going posterior inferior, and then anterior division comes towards the surface. So what is the effect? The leads, high lateral leads, will show deflection due to anterior division. Will show deflection due to anterior division first. They will get depolarized first, and then followed by those ones, the leads far away from this side. Again, the leads near the anterior division will show a deflection first, and then that one happening in these leads which are far away, it will be next. So for these leads, because they are near the anterior division, they are going to show, and it will be towards their positive electrode, they will show R, and then posterior division, it will show in inferior leads, these ones, and it will show as S. Same is going to appear here. Now, these ones, because they are near posterior division, they also show theirs first. So it will be this one shows that both they are working. If one of them is blocked, that's where the problem can come in. For example, anterior division is blocked. That's a problem, because even if these ones are there, but this one is blocked, it will not conduct fast compared to this one. This one will conduct fast here, This one will instead be Q and followed by S. Q followed by S. And this one will show RS. Otherwise, this is a normal one. And since it is going away from this, it may appear like this and then down. But in most cases it will be net, it will be negative. So you can take it like that. And then T wave is producing or is due to repolarization. Remember we said that repolarization happens from epicardium to endocardium. Depolarization is in this direction, but repolarization is from outside to inside. Now, T wave is positive. Why is it positive? Because how do we produce a positive deflection? In repolarization, negative charges are moving. Negative charges are moving towards a negative electrode. Or negative charges are moving away from a positive electrode. Repolarization will happen from this side to this side. So it will be moving away from positive electrodes of all these leads. And if it happens like that, we are producing a positive deflection. Another way of producing a negative deflection is when a negative charge is moving towards a positive electrode. So in AVR, T wave will again be negative in AVR. And then in these ones, it will be a positive deflection. I think in limb leads, it is done. In limb leads, it is done. We are talking of a net depolarization vector. So the net depolarization vector, even though the heart is 3D, it has posterior wall, inferior wall, lateral wall, anterior wall, but the net is going towards the apex. This is the base. This is the base of the heart. Base. And then this is the apex. So the base is where we have the atria, and then the apex where so the apex, because of the anatomical positioning of the conduction system, starting from the base to the and the end is to the apex, at the apex. That's why we have it like that. And from here we can tell the normal axis. The normal axis, electrical axis now, it should occur in this direction, as we already indicated, depolarization in that direction. So the normal axis is determined by the highest positive R wave in any lead shows the normal axis. Highest positive R wave shows the normal axis in limb leads. For example, the highest in lead 1 shows the highest positive R wave. It means the electric axis for this depolarization of this heart is going towards lead 1. Or the highest positive is showing in lead 3, meaning the net depolarization vector is going towards lead 3 if it shows the highest positive. For example, this one it is like this, and then this one is like this, short. So meaning it is going away from this one and going towards this one. The more it is going away from the lead, the shorter and more negative it becomes. So for this case, the normal axis can range from here and then to around 110. So the degrees normal axis is between -30, depending on where you're ready from, to positive 110 degrees. From AVL going to in between lead 2, lead 3, and AVF. Or some people, they will say, when you read somewhere, they will say from 0 to 90, positive 90 degrees. But normally, in majority of the people, the normal axis is towards lead 2. In many subjects, is towards lead 2. Lead 2 is at 60 degrees. We shall see how to calculate axis. Don't worry, but that is the normal one. If it is beyond 110, it is right axis deviation. If it is beyond negative 30 degrees, it is left axis deviation. We shall see conditions causing those ones when we start calculating axis. Now, waveform morphologies in chest leads. Again, we said that depolarization vector, we take a vector, the net, we need the net. And the net meaning we have subtracted all, and then the remainder. We said the ventricles depolarize at the same time, and to get the net, meaning you should subtract things in opposite directions. Things going in opposite directions. We also said phases of ventricular depolarization. First one was septal depolarization, and 2, free wall depolarization, and then 3, depolarization of the basal parts of the ventricles of ventricular free wall. Now, this V1 is located towards the right side, and then these V2 to V4 or V5 to V4, they are located anteriorly, and then V5, V6 laterally. So you see these ones are almost going towards negative or opposite direction, V1 and V6. This is a sketch. This is a sketch. It's not accurate, but at least they are trying to go away from each other. So if we factor in the phases of ventricular depolarization, we said septum, first septal depolarization, and is from left to right, like this. This is what we said, left to right. So septal is depolarized in this direction, septum. So if you see this septal depolarization happening in this direction, a wave of depolarization is moving. First, P wave. P waves will be positives in these leads. I'm drawing P wave, P wave. They will be positive because this is the depolarization net. Okay, depolarization is happening in this direction, so it will be moving towards the positive terminals of all these leads. The exception is going to be on V2, V1. Now in V1, this is V1. In V1, left and right atrium, they are positioned differently. The left atrium is behind, and then right atrium is a bit anterior. So depolarization in V1, for correct placement, in V1, P wave can be monophasic like that, fine, but it can be biphasic. Like this, it can be this or this in V1. For the first part to be the right atrium, yes, this one is coming towards lead V1 positive, but for left atrium, because since it is behind, it will be depolarized going the other side. So it will appear as negative to be moving away from positive terminal V1. It will appear like negative. So under that case, it will be first part positive for right atrium, and then next part negative for left atrium. So it is a variation. You can see it like this, you can see it like this. if it is not above the limits we gave, it is normal. But if it appears like this and it's above the limits, it is abnormal. Also, if it is like this, like negative, it shouldn't be like this. This is abnormal. At least it is this or this. So let me take when it's biphasic. I've chosen this one when it's biphasic. If it is biphasic, it has a limit. The first one should be 1.5 amplitude, not more than 1.5, and the negative part should be not more than 1. Deep. The other one is in height. Yeah. So septal depolarization, it is moving towards lead positive charges of lead V1, V2, probably V3, and then V4, V5, V6, it may appear negative because it will be at least almost moving away. But at the same time, the free walls, they are depolarizing. So we are going to sum up. This, in this direction, whatever is going in this direction and this direction, we are summing it up because we are looking for the net vector. So first, ventricular free wall, septal, for V1, it will be positive, but the septum is so small, it will be small r in V1, and it will still be, because now you are moving towards the left, we are making an anti-clockwise movement. We are moving from this side to the other side, anti-clockwise. So this one is a bit, but here we are starting to find a thicker myocardium. The thicker the myocardium, the higher the voltage it produces. If the myocardium is so small, like the septum, the voltage is very small. If it is thicker, like here, and the voltage is a bit big. So here, it will be a bit taller. And then here, see where the myocardium it is passing. It will be a bit taller compared to this one. And then here, it will become even taller. And then it will become even taller. And then even taller. First, no. Sorry. We on septal. Here for septum, it is moving away from the positive terminal V6. It will appear small q, very small q. Even here, very small q. The q is so small, and then here, it may have or it may not have. So we are giving it a very small q. That is for septal. Now next, free wall. Even here it is so small because it is septal. So this one is proportional to this. It is the same. Now next is free wall. Free wall, right? Remember the heart, the left side is thicker than the right side. So if the left side is thicker than the right side, which one produces more voltage? The left side. So the left side voltage will cancel. It will cancel the right side voltage. We have this voltage going this side, because it is voltage, we are showing it with the arrow and direction. And then for the left side, we have this. The length of these are vectors, length of the arrow shows the magnitude, and then the arrow shows the direction. The net, this minus this, maybe this one, for example, this one is 5, and this one is 19. 19 minus 5, it will give 14. 14 going which side? 14 will be going this side. So the net is going this side. So this net will be moving away from V1. That net, again, what did we do? Free walls are depolarized at the same time, but the right side is thinner than the left side. A thicker myocardium produces more voltage compared to the thin myocardium. So, with intact bundle branches, this free wall is depolarized going that side, and then for the left is polarized going this side. Since they are at the same time, we need to find the net. For example, we gave this one is producing 5 millivolts, and this one is producing 19 millivolts. They are in opposite direction. Where is the net? The net should be 19 minus 5, the B larger minus smaller, or largest minus smallest, and the remainder will be 14 going this side. So this is the 14 remaining going the other side. So we are taking this net, not this 5, not this 19. This net to be moving away from V1, so it is negative. It is also moving away from V2, but it has reduced. This one is this side very deep, and this one is a bit, because we are moving anti-clockwise, we are moving from thinner myocardium to thicker myocardium. It is reducing and increasing. R wave is increasing, S wave depth is reducing. So this one is deeper than this one in V2, and now R wave is increasing because we are moving. This is called transition, R wave progression from V1 to V6. That's what we want. R wave in V1 is purely septal, it is very small. But if you go in V2, you start adding some free wall. And if you go to V3, you have added a significant amount of free wall. So R is taller there, and then S wave amplitude or depth is decreasing. And then V3, V4, septal, purely septal, very small. And then this net is moving towards, almost towards the positive electrode of V4. So it is taller than this one. So it is like that. In V5, now it is purely going to taller, and then in V6, purely going towards the positive electrode, tallest. Now we have finished the free walls. Now next is basal walls can be seen or not. So basal walls, if we are to depolarize the bases, these are the bases, they will depolarize going that side. They will depolarize going that side. So it can appear because these ones are small, this is so small compared to this, it will appear as an S, very small S, very small S, very small S, and then sometimes S is not there, because if it happens S R, this side it will be R. We don't want that. If it's S, then it is part of this one. It is part of this one. So it will be like this. Then the next one, it is T. T is positive. Like that. Whew. It is done. Yeah. So these are the normal waveforms. In V5, from V1 to V6, we have a trend. R wave amplitude increasing and S wave amplitude decreasing. By the time we reach to V6, S wave is very short, but in V1 it was deep. By the time we reach to V6, R wave is tall, but by the time we were in V1, it was so small. That one is called R wave progression. And what if the exchange zone happened somewhere where S and R are equal? It can happen in any of these. V3 or V4, it is called the transition zone. If it happens in V2, transition happens in V2, that is early transition. It shows some rotation clockwise. And then if it happens in B5, that is late transition. It is called anti-clockwise rotation of the electrical axis in the chest leads. And it can occur in many pathological states. Yeah, but we are not seeing them now. So that's all for today. This is what we had. Thank you. Next time, we are looking at the normal ECG and all the parameters, a sample. That's what I'm saying, a sample of a normal ECG, and how to calculate heart rate, axis, so forth and so on and so forth.